All right, good afternoon, everybody. Thank you for being with us today. On behalf of the Texas Indigent Defense Commission's Family Protection Mentorship Program, I am honored to welcome you to this presentation, Trauma-Informed Client Interviewing Techniques. The CLE number, we are accredited by the State Bar of Texas for 1 hour of CLE credit. The course number is in the chat, but for those who can't see it, the number is 174-251-577. We are very lucky to have with us today Kayla Bennett and Ben Wolff from the Texas Office of Capital and Forensic Writs, otherwise known as OCFW. OCFW is the public defense office in Texas that represents those sentenced to death in Texas, challenging their death sentences and convictions through state habeas proceedings. Those proceedings are essentially motions for new trial in the trial court. The habeas process starts immediately after the punishment phase of trial results in a verdict recommending a sentence of death. Kayla and Ben handle some of the most serious, difficult cases in Texas. This is tremendously taxing and important work, and we are so grateful to them for giving us their time to learn from them. Kayla Bennett is a mitigation specialist at OCFW. For those unfamiliar with that area of law, a mitigation specialist is a highly trained individual specializing in assisting the defense team, typically in capital cases, but not always, in investigating a client's experiences with trauma, mental illness, and conducting a multi-generational investigation into the client's life story, along with any other information that can assist the defense team in advocating for a sentence less than death or otherwise less punitive sentence. Mitigation specialists must be trained in identifying mental illness and assisting the defense team in investigating claims relevant to mental illness. There are lots and lots of standards in Texas and nationally relating to the role of the mitigation specialist, but for our purposes, they are highly trained at establishing rapport with clients who have mental illness, and Kayla is particularly skilled in this area. Before working with OCFW, she supervised the social work practice and client services at the Public Defender's Office in Travis County. She served as a mitigation specialist in New York's federal system in the Southern District of New York, advocating for better sentencing outcomes for clients. She worked for the Bronx Defenders as a social worker and has a master's in social work. She worked as a horticultural specialist at Rikers Island. She's been trained in New York City's Institute for Contemporary Psychotherapy on the treatment and neuroscience of post-traumatic stress disorder, and we are very lucky to have her here. Ben Wolff is the director of the Texas Office of Capital and Forensic Writs, where he has served almost 10 years, including as my supervisor, where I learned so much from him about building rapport with mentally ill clients in very challenging cases. Ben has extensive experience in this area, starting his career as a mitigation specialist and a defense-initiated victim outreach specialist on behalf of counsel in capital cases. He was a supervisor at the Bronx Defenders and a post-conviction attorney with the Texas Defender Service, representing those sentenced to death in state and federal post-conviction proceedings. I want to thank Ben and Kayla for giving us your precious time and guidance. I'm going to ask, they've expressed that they're fine with people jumping in and asking questions, but we're also going to have a facilitated discussion at the end, so also feel free to hold your questions if you prefer. And with that, I'll turn it over to Kayla and Ben.
Thank you, Natalie. I think we're going to figure out how to share our PowerPoint.
Yeah.
Quick.
Oh, here. Can you turn it on, please? All right.
You got it.
Okay. I think that one.
Should be working.
Yeah.
Yeah.
Okay.
Are you guys able to see the presentation?
Yeah.
Awesome.
Anybody else having problems? I think it's good.
Okay. So hello, everybody.
It looks like it's loading on my end. It could just be.
Okay.
We're getting chats saying yes, that it looks good. Carrie, hopefully you catch up soon.
Yeah, it came up. Sorry.
Okay, great.
So hi, everybody. Thanks for joining us. Just to start, our office is in the middle of a big move, which is why we're surrounded by stuff and look like we're in a storage closet. So please pardon that.
Under normal circumstances, it just looks like a closet with less storage.
So Ben and I are going to kind of do an overview of mental health and trauma, and then we'll leave some time for discussion at the end if you guys have questions. But we'll go through just kind of an overview of mental health, the stigma and criminalization of mental illness, how to identify mental health symptoms, an overview of sort of common mental health diagnoses that we see, and then how to respond to mental health symptoms in the moment when you're with clients. And for trauma, we'll do an overview of basic neurobiology of trauma and how that works, common trauma responses and diagnoses, and how to do trauma responsive interviewing and grounding techniques with your clients. So just to define mental illness is a condition that disrupts a person's thinking, feeling, and mood, their ability to relate to others, and their daily functioning. Mental illness is very common and also very treatable. So about 1 in 4 people will be diagnosed with a mental illness in their lifetime. And most mental illnesses can be treated effectively with medication, therapy, diet, exercise, support. So one important thing to keep in mind is that mental illness, like other physical health problems, is common and very treatable. What mental illness is not is something that people need to get over, imaginary, a character flaw, a weakness, violent. People with mental illness are actually more likely to be victims of violence than to perpetuate it. So all things to keep in mind when you're working with people who have a mental illness. So mental illness, the origins of mental illness can be very diverse. It can happen from trauma. There's a genetic component to a lot of mental illnesses. The environments that we're raised in can contribute to mental illness, and brain physiology. So when you're working with people with mental illness, it's good to just keep all of this in mind. If people have family members who have schizophrenia, bipolar disorder, that might be something that's inherited. If you're growing up in environments with different kind of environmental toxins or different kind of stressors, that can contribute to developing mental illness. And then trauma can also change the way that our brain is wired, and we'll talk more about that later. But all of these can have effects on what kind of mental illnesses people develop and how and when. So one thing to keep in mind about mental illness is that there's still a lot of stigma around it, and people, because of that stigma, might have a hard time talking about it at first, might not have talked to other people about it, and it might affect how they see themselves, how they interact with you. So it's good to just keep in mind what people have experienced, what they might have experienced when you're trying to talk with people about it.
And also, I think it's fair to say too that someone could be profoundly mentally ill without having it be papered anywhere. Right. So because of the stigma, because of lack of resources and things, someone could be 35 years old and, have been going through their life with, very serious mental illness, but, and have prior contacts with, the legal system, but haven't been flagged before as mentally ill.
Yeah, definitely. That's a great point. And a lot of people haven't had access to treatment or to resources for that. And I was actually just interviewing this jail psychologist for one of our cases a couple weeks ago, and he was saying that the vast majority of clients that he sees in the jail, most of them have not had treatment before, even people who have really severe mental illness. So something to, definitely not take for granted. So in terms of identifying mental illness, there's a few different ways that might kind of clue you in that that's going on with one of your clients. The first one is different verbal things that you might see. So this can be unusual speech patterns. If your client is talking slower than you would expect, or like really pressured and quickly, or they're repeating a lot of words. or if what they're saying is kind of like nonsensical, or it seems like word salad, like they're just saying a lot of things that don't really go together. Those can all be unusual speech patterns that can kind of flag that that might be something to look at. Also, illogical thoughts. So this can look like kind of loose thoughts that don't really associate with each other, really grandiose ideas. So like, you know, people thinking that they know celebrities, or there can also be persecutory thoughts, like people thinking they're followed or being recorded, or the FBI is after them. Sometimes that's true, sometimes it's mental illness.
Right. Also, kind of religiosity is kind of a thorny one too, right? If they, someone, could very easily, have a grandiose delusion of a special relationship with God, and and that is oftentimes normalized in as religiosity, when it's in fact a mental health symptomatology.
Yeah, and with a lot of this stuff, it's different things for different people. There's different cultural influences, but these are just sort of things to keep in mind that, like, oh, maybe this is something I should think about or look at. Also, extremes or inappropriate hostility or excitement. So if someone's talking really loudly, if they're sort of agitated, if they're threatening harm, all of those can be verbal signs too for mental illness.
Right, and so I was talking with a client last week, and who was we talked for about an hour, and I filled probably 3 minutes of that conversation.
Yeah.
A lot of the speech was very, very pressured, tangential, going from topic to topic to topic in ways that, made sense to him. But, I was having to kind of sketch out.
So we just talked about verbal observations. There's also behavioral observations. So this can be someone's physical appearance or how they're moving their body. So it's also good to take note of this when you see people. Do they look disheveled? Is what they're wearing appropriate to the environment they're in? Is anything about the way that they're dressed bizarre? The way that they're moving their body and their posture. Is there any kind of strange posture or mannerisms, pacing, agitation, responding to voices that you're not hearing, lack of awareness of their surroundings? All of this can be clues as well. So this is in the middle, verbal, behavioral, environmental evidence that we observe. And on the outside, you see medical conditions, mental health diagnoses, substance use, and situational stress. So this is just to say that a lot of the stuff we've mentioned could be caused by other things too. So it's good to take a comprehensive assessment that is taking into account all of these different factors that might be contributing to your client's presentation and behavior. And not just assume that it's one thing or the other, but kind of look at all of it and see how it interacts and fits together. The different characteristics of mental illness, as we were saying before, that mental illness is a disorder that affects your mood, your thought, your perception. And so in terms of mood, this can look like mood swings, really extreme emotions, like somebody going from laughing and being really happy to crying and being really sad, and that kind of going up and down within a short time period. It can look like a reduced emotional response. So if somebody's sort of shut down and dissociated, that can be a sign of trauma or another mental illness. In terms of what you see in thought, there can be delusions or hallucinations, preoccupation with certain things. And then, as I said, perception is more hallucinations, like seeing or hearing things that aren't there. So we're going to just do kind of an overview of some of the common major mental illnesses that we come into contact with a lot, just to kind of give you an idea of what those are and what to look out for. We are typically not diagnosing our clients, but it's good to just have a general idea of what some of these are, so that when you see some of the symptoms, you have more of an idea of what to investigate and what kind of resources that your client might benefit from.
So the reason why we sometimes, I mean, we'll sometimes embrace diagnoses, when it's in our client's interest to do so, but a lot of times we don't focus on the actual diagnosis, because in the work that we do, we try to think about what is kind of mitigating evidence, and the label of isn't mitigating in and of itself, and so we try to focus on how the symptoms of that mental illness kind of affect our client, right? So there's a lot of kind of heterogeneity and overlap between different mental health disorders and among mental health disorders, and so, a lot of times in our work, at least, we try to stay away from the exact diagnostic label, and try to focus on, well, if our client, has these symptoms, how it, impacts the way that, they interact with the world, how the world sees them.
Mm-hmm.
But that said, schizophrenia. And if you're going to have a diagnosis, this is a good one.
Yeah, so some of the things that you see with people who have schizophrenia, delusions, hallucinations, disorganized speech, disorganized behavior. People can present bizarre, angry, accusatory, confused. All of these things to just tip you off that maybe something's happening. And like Ben was saying, all of these mental health issues can present really differently, and the label itself isn't always so important, but it's like, how do these symptoms or these things that this person is experiencing affect their life and affect what's happening for them now, and how can we help explain that and help mitigate using that information. So another thing that gets confusing sometimes is delusions versus hallucinations. So just kind of a basic definition of both of those. Delusions are beliefs, so they're firm, they're fixed, they're false beliefs that are contrary to the person's cultural and economic background. And hallucinations are sensory perceptions. So hallucinations are seeing things, hearing things that aren't necessarily there. Delusions are things like feeling things. Yeah, it's like sensory perceptions that you have, like feeling like bugs are crawling on you or hearing voices. And a delusion is a belief about the world or about yourself. So like you're being followed, or you work for the FBI undercover, things like that. So when you are working with clients who might be experiencing psychosis, there are a couple of things to keep in mind. You want to keep your statements really short, so don't speak in really long paragraphs without stopping. You want to have really short sentences and check in and make sure that your clients are getting it. Just give one message at a time. Don't give someone too many choices at once, and clearly define your role. And you might have to do that a couple of times just so they remember who you are and who they're talking to and what you're doing for them. So in terms of responding to delusions and hallucinations, don't ever argue with someone who's experiencing that. Recognize that what they're experiencing is genuinely experienced by them. It's real for them. Accept that this is their reality. Don't try to contradict it. Don't try to say, oh, that's not happening or anything like that. Make an alliance with your client, and you can reality test. You can kind of acknowledge that what you're seeing and what they're experiencing are different, but don't try to convince them that it's not happening. You want to try to stay on their side and build rapport with them. Anything else you want to?
No, I mean, I think that sometimes, this comes into conflict with the realities of, like day-to-day lawyering sometimes, and so like if you're And so, a lot of times, like if you're just focusing on like, okay, I have, this, I have to talk to this client for this purpose, and then, and then we're going to court, and your client is experiencing the symptoms of hallucinations or delusions or some other kind of psychosis. Um, the it's you're gonna have to try to force yourself to be patient.
Yeah.
And and take time with it, because I mean, I've been there, I've never done parental representation, but I used to do trial level criminal defense work, and would meet people at magistration, and and then would try to talk to them, and would have 20 minutes, 10 minutes sometimes, with different people. And so I have things I want to cover, and the just have to give it time.
So another major mental illness that we come across is major depressive disorder. So these are some of the criteria for that: depressed mood, diminished interest or pleasure in things, weight change, insomnia, hypersomnia, so sleeping more or less than usual, psychomotor change, loss of energy or fatigue, feelings of worthlessness or guilt, having a hard time concentrating, and recurrent thoughts of death or suicidality. So if you are seeing any of these in your client, it might be worth asking them about it, or doing various suicide assessments if that comes up. And then bipolar disorder is a mood disorder. So it's shifts in mood, energy, and functioning. There are generally episodes of depression and mania that can last from days to months. And that can look like, mania can be having more energy than usual. It can also be being more irritable than usual. Oh, great.
Yeah.
Elated mood, increased activity. So yeah, these are just other things to look out for. I think mood disorders and psychosis are things that we run into a lot. So just to have kind of some of these symptoms in the back of your mind when you're talking to people.
And sometimes it comes up in just in terms of the hypersexuality in like a manic episode, is that you see someone who's otherwise got their life together and in a committed relationship going through a manic episode, and then they start start sleeping around person after person after person, in ways that are kind of outside of the norm, and it's not because that's kind of a typical pattern, or but it's a reflection of kind of the mania of the hypersexuality.
So that's sort of the big overview of the mental health stuff. We're going to talk about trauma next. So these are a couple definitions of trauma. Trauma results from an event, a series of events, or set of circumstances that is experienced by an individual as physically or emotionally harmful or threatening, and that has lasting adverse effects on the individual's functioning and physical, social, emotional, or spiritual well-being. Trauma is when we have encountered an out-of-control, frightening experience that has disconnected us from all sense of resourcefulness, safety, coping, or love.
And so just so note that we're talking about trauma, not PTSD. Trauma is what we like to focus on, rather than the the diagnostic label of PTSD. I mean, sometimes people who have experienced really impactful traumatic events will suffer what's kind of defined as PTSD in the DSM, but but we really try to, focus on, on the traumatic events and how they're impacting our clients' lives.
Mhm. And on that note, there are a lot of different types of trauma. So sometimes when we think about trauma, we think about just single incident trauma, which is, like sexual assault or natural disaster. But trauma can also be developmental or complex trauma. So this happens in early life. It can be attachment trauma. It can be neglect. There's also collective, historical, structural trauma like police violence, slavery, racism, homophobia. So all of these things can be traumatic, even if they don't necessarily fall into PTSD.
And so I'd also kind of mention here that either you are representing parents in the kind of the family parental regulation system that our government has, and so and their children may have been taken away, and so you're entering the relationship through a lens of trauma, and the viewed empathetically, your client, may and one of the hurdles that you have to get through, just naming it, right, in your attorney-client relationship is that your client might identify you with that trauma, with that system.
Mm-hmm. So one of the ways that we look for trauma is adverse childhood experiences questions. This was a big study that was done looking at adverse childhood experiences early in life and the outcomes for people later in life. And generally it's given like a 10-question survey asking if clients have experienced any of these things: physical, sexual, verbal abuse, emotional neglect, separation or divorce, etc. And there's a correlation between traumatic things that happen early in life and later in life outcomes. So if you're assessing for trauma, this is kind of a common way to do that. And as I was saying, the impact is linked to problems later in life, like health problems, mental illness, substance use, attachment disorders, reduced opportunity, and impaired well-being. So if your client has experienced any of those ACEs, the likelihood that they will experience the things in this list will increase with the number of ACEs that they experienced.
And can you define briefly attachment disorders?
Yeah, so like we were talking about earlier, some of this trauma can be developmental trauma. So how children interact with their caregivers really early in life, whether their caregivers are really attuned and responsive or not able to be that way, can affect the relationships that people develop, how they learn to manage their own emotions and soothe themselves. And the quality of those early relationships can lead to attachment disorders later in life. And yeah, that's it. So this is just kind of a visual that shows the impact of ACEs over time. So one of the things that they found is that the more ACEs that you have, it can lead to earlier death. And this is kind of the mechanism by which that happens. So there's adverse childhood experiences, disrupted neurodevelopment as a result, social, emotional, and cognitive impairments, adoption of health risk behaviors, disease, disability, and social problems. So this is kind of how those early experiences lead to these later outcomes. So when trauma happens, our body is reacting to a perceived threat to our safety. And how we deal with that is our body kind of prepares us to either fight, flight, or freeze, which I'm sure you've all heard of. So you become flooded with stress hormones, your heart rate increases, your blood pressure goes up, your breathing gets quicker, your eyes widen, your blood flows to your muscles, your digestion stops, your hearing attunes to sounds of danger. Basically, your body prepares you to respond to the worst thing that's happening, and everything else kind of shuts down. So your digestion stops, your higher cognitive abilities stop, and your body prepares to do what it needs to do in the moment to keep you safe. And that generally looks like fighting, flight, or freeze. And this isn't something that you're like consciously choosing in the moment. Your body is just responding automatically to what's happening. So your body might perceive, okay, the best thing you can do is fight or run away. Or your body might perceive like, this is kind of a hopeless situation. There's nothing I can do. The best way to keep me safe is to just freeze and dissociate. So whatever happens, you're not consciously making that choice. It's kind of an automatic thing that's happening. And it's important to keep that in mind, because some people after traumatic events will feel like it's their fault, or I should have done something else, or why did I do that? Why couldn't I move? And so sometimes some psychoeducation around that can be really helpful, that, you know, your body was determining how to keep you alive, and this is the method that it chose, and that was outside your control. So as I mentioned a little bit before, one of the other things that happens during a traumatic event is that your higher brain functions are kind of turned off. And so your brain stores information differently during a traumatic event than it does during a neutral or positive event. And this happens because of changes in the nervous system and the shifts in brain activity. So this is one of the reasons why people don't always remember traumatic events in a really linear way, because those memories are not stored how normal memories are. And it's important to keep that in mind too, when you're trying to explain trauma to other people, or explain why your client did experience this but might not remember all of it, or even just when talking to your client about it. Just remembering that it's not stored in the same way as an average event. So one of the things that happens when people have experienced trauma is that can stay with them after the fact. And it can be difficult to get your body to feel safe again, which can look like having a hard time concentrating, changes in sleep or eating patterns, changes in your mood, not being able to stop thinking about the event, and having a hard time making sense of what happened. So these are other things just to keep in mind when you're working with clients. If you're seeing any of these things, that might be a clue to you that they've experienced trauma. And these are some of the responses. It can be re-experiencing, which can be intrusive thoughts about the event, avoiding things that trigger the event, alterations in how you think about the world, and changes in arousal and reactivity. So being like hypo aroused after the event, which the next graph will kind of show. So generally in our life, we live in what we call the window of tolerance. So you're able to think, you're able to feel, you're able to have perspective, to kind of deal with what comes at you. You know, you might get sad or afraid or whatever, but you can kind of talk to yourself about it and find some more kind of groundedness and balance. But when you've experienced trauma, sometimes you go into hyperarousal or hypoarousal. So hypoarousal is sort of like that freeze response. You're shut down, you're dissociated, you're flat, you're numb, you're disconnected. And hyperarousal is the opposite of that, is being above the window of tolerance. So you can be hyperreactive, you can have really intense emotions or reactions. Like you can be constantly on alert and sort of scanning for what's happening so that you're prepared for any danger that comes. And when you're in those two states, you're not in, it's sort of like re-experiencing that traumatic event. So similarly, all of those higher brain functions and the ability to like relate to people are turned off. So if you have a client that's in one of these states, you want to help get them back into the window of tolerance while you're talking with them. Otherwise, one, you know, they're in a state that's kind of difficult and upsetting and could be uncomfortable for them. But also everything that you're saying to them is not going to stick. They're not going to remember what you're saying. They're not going to be able to process it. So if you're noticing that your client has sort of shut down, they're not looking at you, their arms are crossed, or you see them like looking around and scanning and like sort of fidgety, then you might want to do a grounding exercise to kind of bring them back into this window of tolerance before you continue talking. So grounding, when someone's outside the window of tolerance, the higher brain functions aren't available, communicating in the state is futile, you have to ground. And that will help increase the awareness of what's happening now and bringing your clients back into the present moment so you can reconnect with them and communicate with them. And this is just some examples of when you can use grounding. We kind of already talked about this. But if you see that your client is overwhelmed or shut down or is being triggered, that's a sign to you that you might need to pause and do some grounding before you keep going. So there's a few different kinds of grounding you can do. And like I was saying before, the point of grounding is to get your client back into this present moment and to get those higher brain functions back on. And these are a couple of ways you can do that. Mental grounding. You can ask your client to describe their environment in detail using all 5 senses. So you can ask them, like, tell me 3 things that you can see. What are 2 things that you can hear? What are a few things that you can feel? And just have them go through that. You can play different category games, like pick a category and ask them to name some things in it. Describe an everyday activity that they do in really great detail to you. Counting games, math games, anything that kind of forces that more cognitive brain to kind of come back online. You can also do physical grounding. So that can be doing breathing exercises, any kind of sensory stuff. If you have access to that, often when we're meeting with people, who are in custody, we don't have that. But we can also have them plant their feet on the ground, move their shoulders, roll their head around, tense and release their body.
Fidget toys.
Fidget toys, yeah.
Right.
And sometimes if you're meeting with people in office, you can have candles or oils that have smells to them, just anything that gets them back into their senses, into their physical body. And then the last one is soothing grounding. So this can be, really good if someone is kind of re-experiencing something or is triggered and is in a state of active kind of fear or panic. They can repeat safety statements. So I am safe, I'm okay, I'm here with Ben, no one is harming me. You can ask them to describe in detail a person that they really love and that makes them feel really safe, or describe a safe place in detail. And all of that can bring them back again into a place that feels more safe and secure.
And you could do it without would you say that you could do it without naming it as a grounding technique? But
Yeah.
in terms of in the conversation, you see that your client is getting dysregulated. He can shift gears and ask them about a safe topic that for the purpose not so much of information gathering but of grounding.
Totally. And you can do this in a smaller scale too. So sometimes if I've been talking with clients about really heavy stuff for a long time, I'll say you mentioned your grandma earlier, what kind of food did you guys used to make together? And just go totally in the other direction to something that's not as threatening. And you always want to end on a place that's more like that, which we'll get into more too. But so just things to keep in mind in terms of trauma responsive practice. And this is good to do with everyone, whether you know that they've experienced trauma or not, because many people have. And so it's good just to practice this way all the time. But the escape protocol is something that was developed by some trauma therapists in New York. And it stands for every client, social support, choice and control, anticipation, planning, every time. So just things to keep in mind. Do it with everybody. Try to help people connect to social support. Give them as much choice and control as you can. Trauma as an experience is losing control. So trying to give people as much of that back as you're able to. Anticipation, planning, that just means giving people a heads up so they know what to expect and doing it every time. So escape is just kind of a way to keep all those things in mind when you're meeting with people. So trauma responsive interviewing, the 3 E's to think about when you're looking at trauma. So when you're, specifically interviewing your clients about traumatic experiences, these are things to keep in mind. It can be single event or something that happened repeatedly over time. How someone experiences traumatic events is different for every single person. So you can have two siblings that lived in the same house and have totally different reactions to the same event. And look at how that event has affected what came after it. So the adverse effects resulting from that trauma, how it shaped and defined your client, how it is, you know, in their life now, what it means to them now. Just think about it sort of in a more comprehensive way.
So what are some of the factors that protect people from trauma? If there's, even, apart from the sibling context, so like two people experience the same trauma, one person has more, clinically significant after effects and than the other person. What kind of factors might be at play?
So a lot. I think one thing I'll say too is that escape protocol was initially designed for first responders. So when like EMTs were responding to people who had just been in a major car accident or in a burning building. And so how that trauma is dealt with right when it happens can be a big intervention as to like how it goes after that. So right after the trauma, was someone able to make a choice about what happened to them? Like if they went through a sexual assault, were they given agency to decide how they wanted to handle that? Or were they sent to police officers who were not trauma informed? And, so I think how it's responded to can be really important. I think the amount of social support they have in their life at the time and how they're cared for after it happens can be a big thing. I think people have kind of inherent differences genetically and in terms of their mood, and we're all different people when we're born, and so people have kind of internal resources that are different. Yeah, the environments that they're in, the access to care, mental health and healthcare that they have. Yeah, there's a million things. So these are the 5 pillars of trauma-informed care. So there's safety, choice, empowerment, collaboration, and transparency and trustworthiness. So we'll go through each one of these, but when you're working with clients who've experienced trauma, these are just 5 things to keep in mind as kind of the best practice. So in terms of safety, to engage with you, a person must know that they're safe. So you can always ask what someone needs to feel safe, how you can create a safer environment, explain who you are and what your role is, encourage clients to ask you questions, build rapport before diving into big questions, use frequent check-ins throughout the interview, and leave the client grounded before ending the meeting, and asking people's preferred names and pronouns. So, we don't always meet with clients in the best possible conditions, but trying to make the best of what you have available. And building rapport before diving into big questions. So like Ben was saying, we don't always have a ton of time, but when you do, try to, establish some relationship with your client before you get into the really hard stuff. Just like, any of you who've ever been to therapy, it probably is, at least I'll speak for myself. When I meet with my therapist for the first time, I'm like, I'm not telling you anything for a year and a half. Like, there's no way I'm doing that. I don't know if you are. So it's the same with your clients. Try to, give them some time to trust you and open up to you before you ask them about the hardest things when you're able to do that.
Right. I mean, we oftentimes, in our cases, generally speaking, we might, go through like the prior history of the case, and someone who has a very profound kind of trauma history will have told someone, early on in the case, no, I was never abused, right? And the reason why that was, I mean, and that's a thing that we have to kind of deal with, right? But the reason why the client said that is that they didn't know, they didn't have any trust, right? If like the best way to find out whether a client has ever been sexually abused is not just to ask them, but because you're meeting them and, the first first hour, and and you're, kind of buttering them up, and then say, hey, were you ever sexually abused? They're going to say no. Because they still don't know you. And so you just kind of, and that can be frustrating, but it's something that, you just kind of have to be cognizant of and try to work around, and try to build up and establish relationships, or establish rapport, so that clients, witnesses, whomever are comfortable divulging their deep dark secrets. And then once they divulge them, kind of, not to skip ahead, but kind of, can honor that.
So the next one is transparency and trustworthiness. So this is really important in terms of building rapport and trust with your client. If they are going to open up to you and, have some trust in you, you have to show them that you're worthy of that. So that can look like being really consistent, being transparent with what you do, doing what you say that you're going to do. So if you say you're going to go see your client next week on Tuesday, go see your client next week on Tuesday. Always explain to them why you're doing what you're doing, what will happen next. Give them, relaxed, unhurried, and focused attention. Again, these are kind of best practices. Sometimes we have 10 minutes in arraignments to talk to people. Don't overpromise, manage your expectations. So don't do what you want to do what you're actually going to do, and make sure that you follow through on what you say. Use language that your clients can understand. And then always summarize and recap what the next steps are. And you can also ask your client, like, hey, we talked about a lot today. What's your understanding of what's happening and what's going on next? Just to make sure that you guys are on the same page, that they don't have any questions, that they understood everything. And then, as we said before, always give choices when you can. Listen to what your client is telling you, what they want. Validate any concerns. Give them the choice to share. So again, not always possible, but when it is, you can say to your client, like, hey, here are some things we have to discuss today. Where do you want to start? Give them the ability to pause or stop if they're feeling overwhelmed. You can also, I like to give my clients a heads up, like if they mentioned something to me, but they didn't really want to get into it at the time, I can say, like, hey, we're not going to talk about this time, but the next time I come see you, I'm going to want to ask you some more questions about that, just so that they have a heads up and can prepare themselves to get into it, instead of, surprising them with it.
And, one of the things that, and this, that's, I'll just bring it up. It's, kind of unique to our context, but, when we're interviewing clients about trauma, have to be cognizant of the fact that, our clients who are death sentenced are in their cells. Then when we go and visit them, they're brought out of their cell, they're strip searched to and from each legal visit. Yeah. And so that is, something that is a thing that is unavoidable. And, it's a layer that, you kind of have to take into account in terms of clients being, needing to prepare themselves for, difficult conversations.
Yeah. And that's also, a good reminder to just check in with clients when you first get there for a little while, like remind them who you are and the rapport that you have and the trust that you have before you get into any of this stuff. Because a lot of times they have been through something that's already kind of inherently traumatizing. And then collaborating, ask for feedback, ask clients if they have concerns or apprehensions about anything, help them utilize their support systems, help them cope with decisions that might be challenging. Always express gratitude to your clients. And this, we might talk about this later, but one thing that often happens when clients are really vulnerable with you is after you leave, they can have what we call a vulnerability hangover, where they're like, oh my God, I can't believe I said that. I'm so embarrassed. I'm so ashamed. Why did I do that? And so always validating your client and just reminding them that your connection is still the same and that you really value what they've said to you and that you really appreciate the relationship you have with them, just to try to, you know, combat that a little bit and checking in on them afterwards to the extent that you're able to.
Right, like honoring their, and, you know, and complimenting them on their bravery.
Yeah.
Sometimes.
Yeah. And then the last one is just trying to empower your clients. So validating people's feelings in a non-judgmental way, reflective listening, open-ended questions, paraphrasing. So, you know, when your clients tell you something, you can kind of paraphrase it back to them and say, like, did I get that right? And then, you know, if they might say, yeah, or no, that's not exactly right. I more meant this. So those are all ways to kind of, you know, help your client get their voice through in systems that don't value that a lot of the time. And these are just kind of, you know, things to keep in mind. Again, we don't always have access to all of this. When we meet with our clients at Polunsky, the jail where death row is for men, we're like in these terrible booths with these terrible phones, and you don't always have all of this stuff, but to the extent that you can, try to have interviews that are one-on-one, that are confidential. This is so far away. I'm having a hard time reading them.
Prepare. We need to talk
Prepare.
about
Oh yeah, we kind of talked about that
yeah,
already.
yeah.
Prepare your clients as much as you can. Follow up. Ground before leaving. Give your client control of the conversation. Yeah, I mean, these are kind of just a summary of all the stuff that we went over.
Not on the first visit.
Yeah.
Rome wasn't built in a day.
Yeah, exactly. So that's sort of everything. We have a couple discussion questions here, but also I think you guys might have some of your own questions. So we will end it, and we'd love to hear from you guys.
Thanks, Kayla and Ben. Thank you so much. I'm going to stop the recording and